Okay, I guess we might as well get started then. So, welcome everyone to this first translational EPI seminar of the 2021-22 academic year. We're very excited about it. We have Dr. Steph Baral offering a talk today, but I think I'd first give you a little bit of background. So the Translational EPI initiative in the department seeks to develop, share, and implement a conceptual framework to inform both research and practice in an iterative way. This departmental initiative was started in 2017 under the leadership of Dr. David Dowdy and based on principles developed by Dr. Moises Sklo. In 2019, a collaborative team of students and faculty in our department published a wonderful paper on translational EPI in the American Journal of Epidemiology, and I encourage all of you to download it and read it closely for considerations on how research can ultimately improve public health in a meaningful way. After the publication of that article, the Translational EPI initiative grew into a seminar series of invited speakers to share their perspectives on translational EPI. Last year, we had Dr. Sklo, Joseph Flynn, and George Davey Smith share ideas on translational EPI. So I'm delighted to introduce Dr. Steph Baral, who's an associate professor in our department and a prolific epidemiologist focusing on the intersection of epidemiology, human rights, and effective interventions for sexual minorities in parts of Africa and Asia. He has led and collaborated on efforts to implement and evaluate HIV prevention studies globally and for key populations across multiple low and middle income countries. He's also the director of the Key Populations Program for the Center for Public Health and Human Rights at Hopkins. He is a practicing physician in Canada, and he's here to share some thoughts on the coronavirus pandemic and its response. I think he represents the best of Hopkins epidemiology in his outstanding science and public health contributions, but also his principled commitment to human rights and helping marginalized populations. So thank you, Dr. Baral, for offering this talk, and I'll pass it over to you.
Yeah, no, Derek, thank you very much. It's great to be with everybody. It's great to be part of the Translational EPI series, which obviously David led, and I was really honored to participate in, and I think an important part of who we are and what we do in this department. So the title of my talk today is Leveraging an Equity Lens to really think about COVID-19 acquisition transmission risks and also really think about optimal intervention strategies. And I'm gonna, just in terms of disclosures, I'm investigator on NIH and CIHR funded award, CIHR being the sort of mini Canadian version of the NIH, but I take no salary related to any of this work, although I did disclose it in all my NIH disclosures and other support. You have to, by the way, for everybody may know this, you have to estimate what your time is worth if you're not actually taking any money for any of this stuff. But just to say, so outline today, I'm going to talk about first, I think everybody on this call is going to be aware of this, or everybody here is going to be aware of it, but I think it's just important to think about some basics in terms of heterogeneity of risk for infectious diseases. I'll then talk about some of the data that I've been involved with starting very early in March of 2020 in the United States and Canada, looking at what EPI data we have about the sort of variability or heterogeneity and risks for COVID-19 and thinking about sort of the individual network and structural risks. And then I'll talk about what I think of as a fundamental role for equity in COVID-19 and some of the modeling we've done. No COVID-19 talk can happen without some modeling, so I will present some of our own modeling in this space. And then think about, again, what that tells us about the potential impact of equitable strategies. So again, I think this group here understands that heterogeneity is a fundamental principle of infectious diseases, that people are in risk for basically any infectious disease around the world. And that the idea of equity being equally central is that it addresses the conditions that drive those disparities and risks. And so, because in the absence of really paying attention to equity, you actually might even reinforce epidemics, and that has absolutely been the case in many settings, even if they're absolutely well-meaning interventions, that you can sort of further concentrate them. So paying attention to it and being aware of equity remains really critical in both how we sort of conceptualize transmission, but also how we design our intervention strategies. So, for us, the reproductive rate now, I think historically was something that we taught on the first day of EPI, Now it is something that the general public is aware of. They, in some settings, will follow the effective reproductive rate day to day. But I think there's a few things to sort of pay attention to when we look at that, which is to say, one, often what we're looking at is this weighted average of a reproductive rate. But in reality, as we've talked about, there is a continuum of risks. And you can classify some of those risks in at least some additional strata, in terms of high risk or intermediate risk or lower risk. That is probably far more informative than it is just looking at just a single weighted average. And we can also, when we're thinking about transmission risks, start thinking about how there's engagement or interaction between people who are high risk and others who are high risk, intermediate risk, et cetera, because all of that is ultimately going to affect what we think will happen as a result of this, and also what we think will, with no intervention or even with intensive intervention. There's also another dynamic that isn't paid attention to in the reproductive rate, which is really the disproportionate risks of onward transmission. And I'll note that I think this was an area that I engaged in early because we paid a lot of attention to this in HIV as it relates to key populations, and really thinking about not just what is your risk of acquisition, but what is your disproportionate risk of onward transmission to others? And what does that mean then in terms of network-based transmission dynamics? So when we sort of break this down, and I don't want to talk too much about this because I know this is obvious for this group, is I want to sort of think about it in three dynamics that I think are at least three buckets that I think are important. One is understanding the disproportionate risk of exposure that people will have. So what are people's acquisition risks and what is the size of those populations? Again, this idea about what are the disproportionate risks of onward transmission that somebody may have, thinking that also in terms of again, these network level risks. And then the third dynamic when we're trying to understand hospitalization and mortality outcomes is also thinking about the disproportionate risks of severity. And that we recognize across a number of determinants that there's a range of severity associated with any infection for that, or most infections for that matter, but definitely for COVID-19. And that all of this is, and it really takes some effort to try to tease some of these things out across the population. So, sort of historically now, we work very closely with AMFAR, which is the Foundation for AIDS Research. And in March of 2020, I think we were already, cognizant that we were seeing differences in terms of who was being affected by COVID-19. And working with Greg Millett and Chris Beyer, who's on the call, and others, we wanted to try to, to quantify some of those things very early on, because visually you could see concentrations of risk, at least in terms of cases, in disproportionately Black counties. And so we worked with CDC data at the time, and they weren't reporting individual race-based data, but we could look at disproportionately Black counties. And so that is to say that the overall population that is identified as Black or African American is about 13.5%. And so we used as a cutoff, and we dichotomized basically. And those counties that had greater than 13.5% and those that had less. And so to try to understand what are some of the dynamics that are happening in disproportionately Black counties. We also wanted to look at deaths, and I'll just note that in March and April of 2020, there wasn't enough there wasn't enough death data to start seeing some of those differences. I will note when we went back and updated these analyses in about July, you could already see these disparities happening in terms of death data, so that these dynamics were apparent pretty early. And so we wanted to explore, and I'll just note one thing was that while it was harder to show, there was basically almost just this clear relationship across the continuum of percent Black population in a particular county. And so, in the most, diverse counties, and the counties where people were, the proportion of the population was most likely to be Black or African American, you really saw the highest COVID risks. And again, you saw that within really the first 6 weeks to 2 months of this pandemic. And it wasn't at that time, I think, as much part of the narrative in terms of understanding, as I'll talk about now, like the role of these structural determinants. But again, the findings were there, and they were there early. So we wanted to try to understand, like, why is this happening? Because I think we were concerned, as has been the case for HIV and others, that people would start putting forward like a biological hypothesis. And we could already see that that was not the case. And so, for example, one of the things that was really interesting was that in the counties where unemployment was more likely, there was actually a protective rate. and you saw decreases in the disparities between the predominantly Black counties and white counties. And again, I think it was just related. We conceptualized this as really being able to stay home, that if you're unemployed and there is a stay-at-home order in place or some sort of restrictive mandate, you are able to follow those along. One of the things that we thought was interesting and important was percent uninsured, which we thought was, we clearly saw a different relationship to unemployment, but we thought were that these are more day laborers or that are working in gig jobs who don't have health insurance, but are out there working. And then ultimately, I think the thing that we saw clear is even again in these early days was where you had the highest risks were really in places where people had less than one room per person in a household. And so that these sort of household dynamics were starting to explain the differences between predominantly Black counties and less so. And I think, we started seeing some of these trajectories play out very early on. So these are data from May of 2020, starting, I should say, in March of 2020. And we basically, we used quintiles in terms of more diverse counties versus primarily white counties. And you could just see these trajectories playing out in such different ways. Across the South, which we know started their waves really towards that summer, they weren't initially hit as much as the East. But that you could see that in the predominantly white counties, there really wasn't much happening at all. And it was really in these diverse counties where you saw these massive explosions. In the West, you saw similarly, just that in the more diverse counties, you really saw this sort of increase happening. And again, that some of that, what happening in South and Southwest happened much later, or at least a number of months later than it happened in the North and Northeast. And in California, we just used here for Latinx counties, we did a separate paper that I won't talk about as much today, which showed similar themes to predominantly Black counties, but that, we saw these dynamics happening in predominantly Latino counties or Latinx counties in California. And then again, and that these trends have really continued. This is 2020 data, and the differences are extreme. And I just noted, and it really wasn't part of the narrative in terms of like, that cases were happening, and it was just, we weren't talking about who was being affected, which I think for those of us in infectious diseases, I think is a bit of a disconnect when we're talking about sort of overall infections. We want to understand who and why people are being infected, not just how many people are being infected, which I think is critical from like a healthcare utilization standpoint. AmFAR went ahead, I wasn't part of this paper, but AmFAR went ahead and updated these data in October. So inclusive of first and even parts of the second wave in the North and Northeast. And what was so fascinating was the best determinant that they could find was historical redlining. And so, in those counties, the best predictor, and you can see this sort of disconnect happening in the most white counties versus the least white counties, was that the best predictor in those settings was redlining. And so you can see sort of the effect of, housing and people's housing context as being a major predictor ultimately of COVID-19. So what was interesting about this was that, that came out by Kristen Bibbins-Domingo from UCSF, she wrote, "This time must be different." This is a paper from April 2020, noting that like, this actually isn't new in terms of respiratory pandemics. And as somebody who's focused historically on sexually transmitted infections, including HIV and STIs, we pay attention to this. It really is amazing that it was understood to be the case within respiratory viruses, but not commonly discussed. But when you go back and look at it, it is clear. And for H1N1, for example, these are data from the United States showing clear racial disparities that actually continue. These were basically the waves of H1N1. When you look at further data after the availability of the vaccine, which started towards the end of basically in December of 2009, you actually saw these disparities worsen. And I think that is just such a fundamental element that might be playing out now in terms of differential healthcare access and elements around medical mistrust and structural racism. But just to say that this isn't a new finding, that it really followed the trend of H1N1 very closely. And as we've been doing with some of the students, some graduate students in Epi, also other respiratory pandemics. And I think that's, while we know this to be the case in HIV, there's actually a lot of shared determinants between them in terms of homelessness and unemployment and residential segregation and incarceration. We knowing these huge outbreaks that have happened in jails, provider biases, different types of laws really being shared determinants of structural racism between HIV and SARS-CoV-2 or the virus that causes COVID-19. So another thing is to say that this wasn't limited to the United States. I take a particular attention or interest in Sweden because I grew up there. I'm Swedish, and so my mom was in Sweden during COVID-19, and so this was a really interesting analysis that was published in The Lancet about Stockholm, and it really looked at mortality related to COVID-19 compared to all other causes of death for those over 70 in Stockholm, which obviously, or not up, but is the biggest city in Sweden. And what's interesting is that one thing that we know as a determinant is that the more space you have per person per household, the lower your mortality. What was interesting, it was absolutely true for COVID-19 as it is for all other causes of death. But it's really in some of the differences where I thought was really fascinating. So for example, living in a multi-generational household where somebody is of working age, so that is to say somebody's over 70 and somebody's under the age of 66, but over the age of 16, so hypothetically working or most likely working, is really where you start isolating out COVID-19 risks, and you don't see that for all other causes of death. In fact, it's perfectly baseline. You don't see that sort of difference where people live with somebody who was like of school age. They use this cutoff here because under 16, those kids remained in school throughout the entire pandemic. They closed the schools for 16 and above. So they wanted to understand if living with somebody who was, just basically over 70 and under 16 had any effect, and they couldn't isolate that out. And I'll note there's less of them as you see wider confidence intervals there. We saw clear differences in care homes, we know that, but I think other things that we start isolating out COVID-19 risks are incidence of COVID-19 in your community, in your very particular borough, I'll say. And so, this wasn't, you don't see this for other causes of death, that it's really at the network or the neighborhood level where you start seeing COVID-19, and similarly that they could isolate that effect with increased population density. Also something that didn't affect other causes of mortality, but isolated out, that the more population dense your community, which also is a sign normally of lower income communities, the higher your COVID-19 risks were. They further went ahead and in a separate analysis, this is a different group and published in Nature, looking again at differential causes mortality related to COVID-19. And this, they focus on country of birth. And, we know that normally migrants to countries are much healthier than the average populace. And there's this sort of healthy traveler or healthy migrant effect. And that was absolutely, you can absolutely see that if you look at folks that are working age. I always wonder how I can show them, but just to say that, can you guys see this, Derek? Are you able to see my little?
Yes.
Oh, great.
Yes.
Come through.
Yeah. So just to say that, when you see that folks that are born outside of Sweden have lower other causes of mortality, which is absolutely what we'd expect and what we know, but really isolated and extremely high levels of COVID-19 mortality, and that was true both for the people working and as well those that they likely lived with in multi-generational households. And similarly that, that this effect, I will note, was really isolated to Stockholm, and it didn't affect the more rural parts of Sweden. And so just to say that, you start getting this idea that it might be related to other determinants, again, in terms of occupational and living determinants as compared to other things. Now, is it not going to let me? Okay, great. So we wanted to look at this. These are mostly other people's data, or at least the data from Sweden I wasn't involved with, but we wanted to look at this more closely in Ontario. And I did this with a group where we had worked on HIV for a long time, I should say, not in Canada, but abroad. But we wanted to bring that question of structural inequities to the questions of COVID-19. And so these are data, the first set of data I'll show are from March to June of 2020. And we used a series of these different databases, which I can share with you as of interest. But nonetheless, given our healthcare system, we are able to access basically 90% of lab confirmed cases, and we can correlate that to StatScan or census data, so all the way down to what we call the dissemination area, which includes about 400 to 700 people. And so we could look at things like occupation, and we classified people by essential services, which is defined as not being able to work remotely. That could be any number of jobs. It amazingly represents almost over 60% of people. But nonetheless, essential services, education level, household income. We also looked at dwelling related or housing related issues, and then ethnicity as a proxy, for these sort of unmeasured confounding. And indeed, it's exactly what we saw. I'll just say, in our first, in your first model here, you just have this unadjusted odds ratio. We then adjusted it for age and sex, and then had a fully adjusted model. And really, the only thing that continues to be significant are lower educational attainment and a number of people in dwelling. And it really was that lower educational attainment predicted the amount of space that you had in your household. It predicted a number of other determinants, and you could see this clear relationship, as you could see the number of people in the dwelling overall, that higher COVID-19 risks were associated with more people in a household. One finding I just want to bring really attention to is that the unadjusted odds ratio also showed a really extreme gradient according to visible minority status or more diverse neighborhoods, which completely falls away when you adjust for socioeconomics. And I think this finding was a really important finding here to get away from this sort of biological hypothesis. There's nothing biological happening, that these differences completely fall away when you adjust for some very basic social determinants of health. And even without the math, I'll just say, when you zoom in on Toronto, for those of you who don't know, is the core is about a population of about 3 million people, very diverse and interesting city. But similar to other places, is clustered by income in very significant ways. And generally speaking, the more central part of the city is the most expensive part of the city. So you can see in blue in A here, the household income being the highest in the sort of center part. Ethnic diversity being more significant in the northeast and northwest, and recent immigration actually being kind of a mixed route. But what you start seeing, and really clearly, is also the sort of relationship between where people are essential services, where folks who work in essential services. Again, this could be everything from Amazon services to trucking to anything, restaurants, Uber delivery folks, etc. And that the sort of disconnect between suitable housing here, suitable housing is defined as having, again, 1 room per person in a household. In that you see so you see here that you see people who are in essential services working in person, but less likely to have 1 room per person per household, more likely to live in multi-generational households. So here we just sort of mapped out, because this is not for prime time, but just to say that we were mapping this out as the pandemic was going, looking at cases and looking at numbers of essential workers, and just sort of keeping a track of it. And you can just see, even before I get to some of our work quantifying this, that you can start eyeing, when you start co-representing essential workers and COVID-19 cases, that it's extreme. And that the relationship is absolutely the case, and that it is, there's very few places. There were some where you had less essential workers and some outbreaks related to travel initially, because that happens to be where the airport is and where cases were diagnosed. But really, to say that just was not the case anywhere else, and only, again, related to travel. So if you remember those maps I just showed you, and then you start looking at what COVID-19 cases look like, you can see, again, like, you don't have to be an epidemiologist to see there's something going on here, right? That, like, COVID-19 cases are absolutely affecting the parts of the city with essential workers, with more essential workers, and is less affecting, parts of town. And that when you quantify it using, a Gini coefficient, you can say that somewhere that, you can look at the line of equality and eyeball that it's nowhere near. And that's somewhere about 50% of the cases were happening in 25% of the communities. And we have another paper where we've looked at this throughout the 3 waves, and it's continued. In fact, it's gotten worse across the waves. And there was something that we found very early, which was that, between January to March, the epidemic looked very different. And this was an epidemic of people returning. This is like people going to Switzerland and on a vacation to go skiing in the Alps, coming back, and they're generally a wealthier community. But what happens very early, basically, from between March and May, is that there's a really significant transition. And we were sort of thinking this as this epidemiologic transition from being travel-related cases in imports to local transmission and really happening in lower income areas. So higher income travel, lower income local transmission. And again, when you go back historically, it was the same story for H1N1. So it wasn't really groundbreaking, except for the fact that I think it told an important story for COVID-19. So I don't think that anybody in this group, we then wanted to start looking at like what's happening in facilities. And I don't think anybody in this group is surprised by the fact that, you know, facilities and facility-based transmission has been really common in COVID-19. And just as a starting point, we wanted to document that. My clinical services are within homeless shelters. And so, you know, we could see it all around us happening very quickly. Obviously within long-term care facilities, that's where it's more than a 60 times risk. But again, it was to make the point about what was happening in these facilities. But our idea was that like what's happening in those facilities is not disconnected from what's happening in communities around them. And so we wanted to study this in a little bit more detail. Again, we used Lorenz curves and measured Gini coefficients to do that. But what we saw was really interesting because often we talk about healthcare workers really being affected by COVID-19, but it really isn't all healthcare workers, and at least here. And it was really fascinating to see that there was a concentration of cases among healthcare workers in long-term care facilities, personal support workers and others that have very, you know, like frontline and very engaged activities with patients as compared to like, you know, more like history and physical type exams, like really helping people with activities of daily living. And they were really affected by COVID-19. It was less the case among healthcare workers not working in long-term care facilities. And to dig into that even more, there was a relationship between income, long-term care facility workers, and risks. And so what we noted were almost half the cases among long-term care facilities were among staff living in some of the most affected areas. So again, you see this sort of dynamic between what we think of almost as like an oscillating migration between going to your home and your community, then going back to work and realizing that there's transmission happening between the two. Either you're acquiring in your busy household and going to work, or you're acquiring at work and taking it into your household. But there was clear income disparities, and also just in terms of structural inequities and structural racism, that these staff were most likely to live in the areas that are most ranked highest in terms of visible minorities. So, you know, I often show this. I know SARS Part 1 was not a big deal in the United States, but for those of us in Canada, it was a big deal. And this is the link. I always, if folks are interested to read a little bit about what happened in SARS Part 1, because I think there's some really important lessons at that time. SARS Part 1 happened in 2003. It really affected Hong Kong and affected Toronto, where I was doing my residency at the time. And so, you know, it was this real question about like what happened back then, and what can we learn from, and how is that relevant to now? And there were some principles I think laid out after that report. I will note it was that report that caused us. We had our first, like, our public health agency of Canada was formed after that, and provincial public health agencies were formed after that. Before that, we didn't have those. Like, we didn't have a kind of CDC equivalent. And so, but there were some really important principles. So, you know, equity being one of them. So given inequities across society, public health should really aim to do more for those who need more. And social justice is this idea of like wanting to achieve balance between the benefit and the burden of interventions, and participation in terms of really wanting to engage the public in terms of decisions that will affect them. And especially this idea of like designing with communities rather than just for communities. As Chris highlighted, the WHO is now engaged, this idea of community engagement as being fundamental. And translational epi seminar, I'll talk about, you know, what is the public health's role in advancing equity? And so, you know, there's been, this is on the Canadian side, but I don't think it's that different. It's to say that there's like 4 different roles that we can play in this. So we can assess and report on the impact of health inequities. We can partner with other sectors that might be able to better serve communities that are particularly burdened. We can modify and orient our interventions to ensure that they address the inequities that we're seeing in front of us. And we can participate in policy development and ensure that policies are reflective of inequities and responsive to those inequities to, you know, to address them. So, like, how did we do? You know, and not we as in just like the bigger we as in society. there's some really fascinating things that happened over time. So one, I think people may remember this, that Trump deemed the Trump administration deemed meat workers to be essential workers, and that they would continue working, that they wouldn't benefit sort of from the CARES Act and get paid, this sort of support, that they would continue working. And in our early work around this, we saw really clear occupational risks among Latino communities. And so again, the sort of relationship of like how we define a policy of like who's an essential worker and who gets to benefit from these supportive interventions and who doesn't. Other dynamics that we saw very early on was that COVID testing testing services weren't located in racialized communities. And that was super interesting because as we've seen in every city where we've looked, COVID-19 was affecting communities of color and lower income communities, and we weren't setting up testing in those facilities. And I think we could have a more recent conversation about vaccination, but maybe down the line. Another analysis that we are working on that I think was really interesting, and we did this based on the fact that we saw analysis like this in the United States, but the data are a little bit harder to get here because of privacy issues, but was to look at partnering with an organization or a company called Blue Dot to get at mobility data. Because the idea of like stay at home is critical, and we want people to stay at home and to work remotely and minimize, and that we want to try to quantify that. And in the earlier data in the United States, they'd seen a real relationship between income level and the idea of staying home. And so we wanted to try to measure that as well. And I'll just note, pre 2020 and even up until basically February of 2020, higher income folks generally moved more, which is I think might be cognizant of more travel, more ability, et cetera, but they generally moved more. But that changed rapidly. And so this is percent of devices as staying at home. These are normalized data. But just to say that, the highest quintiles were most likely to have devices staying at home. And that that it really is basically almost a dose-response relationship between income, that lower income folks were generally more likely to have their devices still leave home at least once per day. And we looked at the same thing by essential worker status. And again, you could see a very similar dynamic that those that are in the areas where folks are least likely to be essential workers, again, in these demographic or dissemination areas of 400 to 700 people, they were most likely to stay home, and that was least likely the case in areas with most essential workers. So again, you sort of start seeing this idea of like, who can stay home, when we put like a recommendation or even a requirement or a policy in place that recommends that. So I'm going to just show what happened across waves 2 and even waves 3 in Ontario. For those of you who don't know, Ontario is about 15 million people, also a very diverse place. And so I think it may or may not be representative of what happened in states across the United States, but I imagine it's maybe not so different. So, just to say that in wave 1, we saw this initial wave in that first, few months. I'll note, orange here is highest visible minority, blue is least visible minority. In the early days, again, in the least visible minority, you saw most cases, just for like the first, can you guys see my mouse? Can you see this? It's a mystery.
Yeah, we can see it.
Oh, great. Okay, great. So just in that first, basically 4 weeks, you saw higher cases in lowest visible minority, which really was a travel effect. And again, the sort of idea of people coming back from Europe predominantly and bringing COVID with them, bringing the infection with them. I don't mean to stigmatize, but bringing the infection with them. But that transition happens very quickly in the context of wave 1. And sort of there was a little blip here, but functionally wave 1 throughout the summer of 2020, where this local transmission takes over. Things slow down in the summertime, I think, as we know, and then there was a rapid increase. And this is really where you start seeing. So around the end of September is where we had our first stay-at-home order. And you can see that stay-at-home order had a marked effect in higher income, or I should say here, on less diverse areas, and it had essentially no effect in more diverse areas. You could also see that relationship happen by recent immigration. And you could see the relationship very clearly in terms of suitable housing. So that was the case. I'll note this is through November of 2020, so kind of into that second wave. But where you see the relationship the clearest is really in terms of essential services. And that, again, if you were to look, if you had that stay-at-home order come into place, it worked almost immediately for folks who work remotely. Those folks stayed home and they didn't do anything. But in the areas where people continued working, it had what could imagine as very limited effect. I want to present these data because these are, the first author of this paper is Amrita Rao, who I could imagine is a doctoral student at Johns Hopkins, but she jumped in to support some of these analyses and published this paper in Annals of Epidemiology. But what it did is it went right through the end of the second wave, or basically towards the end of the second wave. And you could see, and it also included mortality. And I'll just note, and just to highlight like how concentrated mortality was in this second wave among the most essential workers. It was horrific, and the wards were horrific, and everything was horrific. But it was really concentrated among a very particular demographic, not by occupational status. I'll just show third wave data because this is where now we had the introduction of variants. And so we wanted to see, and I think this paper has just been accepted or is coming out in JAMA Network Open. It should be out any day. It remains a preprint. But just to say here, our third wave, which is basically here, our alpha wave basically was all among essential workers. It was completely flat among non-essential workers, and you just saw it pick up. So it's like the epi. So it's a new virus, or a new variant, obviously, a new variant, but the epidemiology of it in terms of concentrating among essential workers was identical. The transmission sort of patterns and transmission dynamics remained unchanged in the third wave. So just to say, so we wanted to then try to model, like, well, what should we do about this? Like, what does any of this mean? And we conceptualize this as sort of there being two communities, that 25% of the population, or a quarter, have these higher relative risks based on all the things I've just talked about. And that 3/4 of the population are sort of lower risk. And that you can quantify that based on contact rates per day. Because ultimately, your risk of COVID-19 is driven by your contacts. And that in these higher populations, just based on how they live and where they live and how they work and where they work, it sort of predetermines to some extent their contacts, even in the context of highly restrictive intervention strategies. And I'll just say, so we had this piece, I'll note, with somebody I met on social media, Muge Chevik, published in Science, where we tried to make this case in as visual a way as we could, that like, irrespective of what your acquisition risks are, that really the sort of epidemic dynamics of it are really going to be driven by your networks in terms of like, can you work at home? Do you work at home, first of all? And do you live in a house? Or do you work in a factory and live in a big apartment building? Even keeping in mind airborne transmission or not, do you live in these settings? Because ultimately, that is going to be a major determinant in terms of your overall contacts between these two different folks. And here I tried to sort of say the same thing. I'll note the one before was Science, and this is my version. But just to say that, we were just trying to make that case that like, you could have the same exposure and the outcomes are so dramatically different, which again, I don't think is a surprise to anybody here, but I felt like was an important thing, important story to tell, because everybody was like, just make better choices, choose better, do better. And you worry that some of these choices were pre-programmed into kind of the structure of society. So we wanted to try to model that, because if our intervention in an ideal way would say, we want this intervention strategy to decrease transmission by 25% in all networks, and to say that we have our higher risk networks here represented in red, our lower risk networks in blue. And if we could have this intervention have a 25% benefit, we will see, it'll still be higher than it will be among the low risk networks, but we'll see this overall benefit if we can decrease their contacts by a quarter. Obviously, in the low risk areas, if you can decrease their risk by 25%, it virtually eliminates their risks for COVID-19, which I think is somewhat reflective, at least, of what happened locally. But what really happened is that we decreased the high risk groups by about 10%, and we decreased the lower risk groups by 25%. That's sort of indicative of like when we did our contact data, that all our restrictive interventions had about a 10% decrease in the highest risk areas and about a 25% decrease in the lowest risk areas. And so there, what you end up with is, obviously a more pronounced wave and pronounced infections among those already at risk. And by the way, there's spillover to low risk communities, that if the high risk communities are more affected, they similarly won't benefit, although the difference between the two is less pronounced. And so we sort of called this the prevention gap, which is to say that, if we were to better address and to get transmission down by contact rates down by 25% in both the higher risk and the lower risk, that really represented the difference in the pandemic overall trajectory. We took it one step further and we said, well, in a real equity, it wouldn't just be equal benefits to higher risk and lower risk. It would actually be more benefits. Like, we don't provide pre-exposure prophylaxis for HIV to everybody. We provided particular communities that we might provide housing supports and better paid leave and all kinds of very resource-based interventions to more higher risk communities. And so we did that where we just modeled that out and we said, let's leave the low risk communities to fend for themselves with recommendations, and let's really give resources up. And what could we achieve if they didn't go to work or if we were able to provide temporary housing? And we saw really significant benefits in the overall epidemic by really focusing the resources on those at highest risk based on structural risks, including structural racism. So just some conclusions from this work. And I think, the early modeling in COVID-19 had to assume like homogeneity of risks, that everybody's at the same risk. And so, when you looked at then what would be the benefit of like a lockdown, we just said, well, it'll affect and it'll improve the reproductive rate and the contact rate among everybody at about the same level, and that there might be differences in severity. But that's just not the case. And it's, that there is the COVID-19 epidemic, whether, I could have shown data from Michigan, obviously I focused on data from Ontario, that it is marked by heterogeneity, and that heterogeneity is often driven by structural realities with a focus on structural racism, similar to previous respiratory pandemics. And I think there's really a lot of value on leveraging like these data to say, well, what do people need to do the things that we would like them to do? And that it actually takes a lot of work to design those programs, and it's not cheap by any means. But I do think that it presents a path for this sort of intersection between human rights and impact of interventions and aspirations of equity. So with that, I'll thank Sharmista Mishra, is an infectious disease physician and the PI of the Canadian work. Jeff Kwong is similarly a population health physician and a co-PI. A number of folks contributed to the data. Amrita is not here, I'm sorry to say, but she should be, because she obviously first authored a paper that I presented. And Greg Millett and Carlos Rodriguez-Diaz led the paper first among Black and African American, and Carlos for Latino communities. And then the work was funded by CHR. So thanks very much.
Great, thank you. Can you hear me?
Yeah.
Oh, great. Sorry, both Derek and I are having some tech issues here.
Oh,
so
okay.
Apologies. That was wonderful. Thank you so much, Steph. Really important work. So I guess we'll just open it up now for some questions. I see some hands that are being raised. And there's a follow-up question in the chat too.
Okay.
But why don't we go with the hands that are being raised? How about Suravi?
Hello, Dr. Baral. Thank you for such an interesting talk about equity and COVID-19 risk. I was very interested in your modeling of concentrating resources in high-risk networks. I was wondering if you could speak more to identifying high-risk groups, particularly since certain risks like workplace risk may be lower in communities with high levels of unemployment.
Yeah, it's interesting. I mean, ultimately, what we did was we used contact data represented by first mobility in terms of cell phone data and how it's amazing, by the way, and I think maybe all of us are aware of this, like how much data is available in terms of how we're moving around with the recognition that we often move around with our cell phones. And so what we were doing is using our data available for how people in specific all the way down to what's the dissemination area, like I said, representing about 400 to 700 people, we're moving around. And then we, from there, these are ecologic analyses. Like we don't have individual data, but in that same region, we have StatsCan data to look at unemployment, essential worker, even what jobs people have, because it really clusters people who are truckers live in, because 400 to 700 people, I'll note, can be like one building. It can be an apartment building in some settings. You can even have 2 dissemination areas in a single apartment building in some places. And so it's, the analyses are ecologic, but they really are a very fine-tuned level, like I said, all the way down. We did this initially using neighborhood data, which is what we first had access to, but that might be up to 2,000 or 3,000. And then we did what was called the forward sorting area, which is about 1,000, which is the first 3 letters of the postal code, maybe like the first 2 letters of the zip code type thing. But now we were able to go on to what's called the DA. So, I think unemployment seems to be protective where we had data. And again, I think it all just speaks to, like, if somebody tells you to stay home, can you stay home? And if so if you're unemployed, I think you're more able to do that. That was the data, at least earlier on, explaining some of the differences between predominantly African American or Black counties in the United States and white one, or less predominantly, or less than average numbers of African American or Black people in a county. But I think that's sort of how we conceptualize that. So we didn't use unemployment as a risk because it's not been identified as a risk in any of our analyses.
Thank you so much.
Thanks.
Great. I also just want to make the point, Amrita is here, so
right.
Your shout out to her was received. Thumbs up. Chris.
Yeah, Steph, this is coming together so nicely, and it's such compelling data, and I think you really laid it out just with such clarity. You really appreciate that. I think one of the areas that COVID has had the biggest impact on, of course, is education and children, and it's created a unique set of complications for so many people. But it relates also, again, very much to these social determinants, right? So it's one thing to stay home. It's another thing if your schools are open or if the schools are closed. And the educational attainment. And just to say, in Baltimore, we have seen such a devastating impact on those children and families who use the public school system, right, as opposed to people who have private school. And you can see immediately the socioeconomic differential would just be huge. How many families have, tablet or a laptop for each child to be able to attend virtual learning, can afford Wi-Fi, which of course in the city is expensive and is really a luxury good for many people, suddenly becomes an essential. So I just wonder, I know this hasn't been specifically a focus of some of the work you've presented, but if there are data about that, if you know of related work, I think, this is going to be, hopefully we are going to get out on the other side of this pandemic, but the impact on children and adolescents who've lived through it, particularly those in the lower socioeconomic strata, is going to linger.
Yeah, so I'm part of a, the deal is here that I've never been interested in engaging in Canadian academia, but I just said, like, I'm here anyways. I'm not traveling as much.
Right.
So, like, if you want a hand on some of these analyses, here I am, and so indeed, so I'm part of a school tracker project, and we have some really interesting analyses. Like, first, I'd say we used here cutoffs based on school counts to close schools. So, I think if it achieved a certain level of local transmission within the school, they closed the school, and then eventually they closed all the schools. But I'll just say for a number of months they were using this as a cutoff. Now, what you can imagine, it was already being understood, is that schools that are in particularly burdened communities are going to have more cases.
Yep.
And they're going to close faster, and so that absolutely happened. And so people were like so focused on the school, but not really talking about like the community that school was in and the catchment area that school serves. So that was absolutely the case. What's so interesting, and I think is a little bit troubling now, and I'm not in a public, I don't know if it's public or not, but just to say, there seems to have been something else going on where schools in lower income areas closed even faster. And we're not quite sure what that means. They're trying to figure out if it's actually the case, or if there's no doubt that schools in lower income areas closed sooner and more likely to close than schools in wealthier areas. But they're even thinking that even after you adjust for case rates, it looks like schools where it's most likely that the parents are second language folks, so neither English nor French, or we're more likely to close even after adjusting for case counts. And there's a real concern there that, like, in areas with parents with more like power and agency, they fought for their schools to be able to stay open, and that they were more likely to close them, in particularly the areas where the parents were most likely to be essential workers, and were leaving their kids with their grandparents, were leaving their kids with groups and pods and anything, because otherwise, if you don't work, it's just like the system doesn't work. Right. And so just to say that there's something going on with schools here that needs to be looked at, not as much between public and private, because they had to close. Eventually, all the schools closed. The private, obviously, were the last to close. But it really is this dynamic of like very clear continuum, but also something else going on that I think we're going to learn more about over time, about how people made decisions about closing schools where parents weren't as equipped to fight, to try to advocate for their kids.
Yeah. Wow, powerful.
So there's one question in the chat, Steph.
Oh, okay, sorry.
No, that's okay. I can read it. It's a follow-up regarding your point that those with higher income travel more. Is there any evidence on the possible transmission between higher income to lower income communities as a network effect due to these traveling patterns?
Yeah, I mean, I think it's a really important question of like trying to understand the epidemiological transition that seems to happen. And I'll note this happened in a lot of places. I had colleagues looking at this more closely in Europe, even in Australia as a note, and even in New Zealand, local transmission versus like transmission at, cases found at airports on either arrival testing or related, made it past arrival testing and somehow into the community. But I think that what happens, so I don't know that people are traveling into lower income areas, but I think lower income folks, once in a higher income household, there might be like some onward transmission, but it often ends, it's kind of terminal with that household. But as soon as infections make it into like an Amazon, and I'll just note, like, our biggest contributor to infections was Amazon, like unimaginably, and they never closed it. They never closed Amazon, and yet like we had more cases in a single Amazon facility than we did it was like 1,000 cases in just one Amazon facility. But nobody wants to talk about Amazon. But anyway, so just to say that once an infection entered into that community, or that and included even the bus driver on the Amazon route died. You know what I mean? Like, it was so extreme and so everybody was still using transit. And so like, obviously people are masked, but like masks, I think can't overcome like that amount of exposure, at least the way that it was being used. And it was tremendous amounts of mortality in that. So I don't know if it's like that people are traveling into those. I think it's just like once the infection enters into that network, transmission is very rapid. And that I think is not so different from other infectious diseases also, where you just have these high risk networks and it just takes, I think of like people who inject drugs and these, what we used to think of as explosive epidemics in Russia of HIV or Hep C, where just once it enters the network, transmission is extremely rapid. And it just takes that chance event of entering the network.
So interesting. Any other questions?
Can you hear me?
Yeah.
Yes.
Oh, okay, great.
Oh, that's good.
Yeah, maybe just one question. Sorry, I can't see any menu buttons on my Zoom, but I'm using the space bar. But Steph, have you been in a position to persuade or inform policymakers on some of these responses?
Yeah, so I think it's such an important question. So like, I think more of my work has been a little bit more on the front line and in some of this research work, but absolutely, like, I'm a member of one of these. We have this science table here in this province, and I'm a member of the science table, or a member of one of the groups of the science table, I should say. So I think like the science table has called for things like paid leave. Like, we still don't have this like a functional paid leave program. So we've called for some of these structural things. We set up isolation sites that initially, I think at least they existed, but they didn't set it up till September of 2020, and even then it was very limited scale and not well integrated into the testing programs. I think they've done it, but I do think we've like relied a lot more on passive intervention strategies to kind of like help us. So like the idea, like we had stay-at-home orders, so it's like if you just stayed at home, nothing would happen. But it's like almost 70%, over 60% of the populace is still working out of their home during the most restrictive mandate. And so it was to say that like many of us were arguing that like, yes, it's an intensive intervention strategy, but no, it's not actually addressing these risks among 2/3 of the populace that continue to work during these times. So I think at the governmental level, it's not been well received. And I think it's just going to have to, at this point, we're trying to like, integrate lesson learned, hopefully out of this, that we continue to learn to not just focus on overall case counts, but like who's being affected, why they're being affected, and what the implications are for that in terms of intervention strategies. Because I think we have during COVID-19 relied more on kind of uniform strategies than, at least you can still have those, but still thinking about what additional resource-based approaches people may need to avoid infections. Nobody wants to infect anybody else, that we know. I mean, nobody wants to get COVID-19, nobody wants to give anybody COVID-19. So it's just like supporting people in that, to do that.
Wonderful, thank you.
Any, one more question? I think we might have time for a question or comment.
Well, thanks so much, Stefan. We can't wait to see you in Baltimore.
Yeah.
Yes.
Oh, I know.
Yes. Well, Steph, thank you so much.
Sure. Thanks.
Good luck getting back into town.
I will. Thank you.
And yeah, we'll have another seminar like this in just about another month or so. So we'll hope to see you all then. Thank you.
All right. Thanks everyone for
really
coming. We'll see you in October. Yep.
Yes. See you in October.
Great.
Thank you.